I'm Wayne Hodges, the stroke outreach educator at UF Health Jacksonville. I want to talk to you today about the state of the stroke program for 2016. There's been a lot of questions concerning our capabilities and what we're actually doing with the program, and I want to make sure that you're up to date on things. To start with, you need to understand what a stroke center is. There's two basic bodies in the state of Florida that certify stroke centers. One is ACA, the Agency for Healthcare Administration. This is a state of Florida agency. To be certified as an ACA stroke center, either primary or comprehensive, you basically apply with the state, send them a letter stating that you're going to comply with the guidelines for a stroke center as defined by Joint Commission and the literature, and you pay a fee. There's no real site visits associated with it. The other agency is Joint Commission, or the Joint Commission on Accreditation of Hospitals. This is pretty much the gold standard of certifications. There are a couple of other national organizations that certify stroke centers in other states, but ACA and Joint Commission are the only two that I'm aware of within the state. In an ACA certification, you pay your fee, they come in, they will nitpick your program, and then every 2 years they come back and do a site survey to make sure that you're complying with the guidelines for a stroke program. This year, Joint Commission has started one other level of certification that is new. It is a stroke-ready hospital. It's not a primary stroke center. This is a community hospital or a critical access hospital that has the need to treat strokes in their emergency department, but then will be transferring them to a larger stroke center for admission and care by the neurologist. In other words, they have all the necessary parts and pieces together to give drug, to do imaging, to do the necessary lab work, and they can comply with the requirements of a primary stroke center as far as the emergency department goes. Not aware of any hospitals that have reached this certification in the region. I do know a couple of hospitals that are starting to drip drug in these small hospitals and then sending them forward. This is going to become more commonplace as we go forward. Next one is a primary stroke center. And the purpose of a primary stroke center is to give drug within 3 hours. Part of the things that you need to realize is it normally is considered a door-to-needle time of 1 hour, and during that time, patient has to have lab work, which includes platelets and clotting factors, CBC, other lab work has to be done. They have to screen for PT, INR in case the patient is on an anticoagulant of some sort, and they have to do a CT of the head. The CT shows whether or not there's bleeding. It does not show a stroke. You see that in an MRI. And when they do the CT, they're looking for that not bleeding, and then based off of the physical assessment by the physician, usually using the National Institute of Health's stroke score, the determination is that this is most likely a stroke, and we are going to treat it as if it's a stroke. If you see the stroke on a CT, it's usually 3 to 6 hours old or older, and you may well be past your treatment options. Primary centers only have to use the 3-hour window. The 3 to 4.5 hour window for the treatment with TPA is off-label use of the drug. I'll get into that in a little bit further. The other centers that you have are the comprehensive stroke centers. Comprehensive stroke centers comply with the 3-hour window. All of them will have the 3 to 4.5 hour window, and then they have interventional procedures. They have interarterial TPA, where you put a catheter all the way into the brain and inject right at the clot itself to dissolve the clot. You're using much less drug. It's a little bit safer in some patients. And then you have clot retrieval procedures, where you take a device and you go and actually pull the clot out. And then you have research, and you also have neurosurgical support readily available. The neurosurgical support has to be in place for about 2% of the strokes, and these are the aneurysm and bleeding strokes. The two big procedures involved in that are aneurysm coiling and clipping. And then clipping, they have to take off a piece of the skull and go in and almost looks like putting a staple around the aneurysm. In coiling, they put a very fine wire into the aneurysm that then allows the blood to clot around it and basically patches the vessel from the inside. Both of those are done by endovascular neurosurgeons. Now, in the region, we have many stroke centers. We have a whole system of primary stroke centers, and in this region, and the region being northeast Florida all the way through north central Florida, we have 4 comprehensive centers. On the primary side, we have the Baptist Hospital System, Baptist Downtown and Southside, and then Beaches, and their other hospitals are coming online as primary centers. You'll probably see Baptist Nassau come on as a stroke-ready hospital. St. Vincent's Downtown and Southside are primary centers. You may even see St. Vincent's in Clay County become a stroke-ready or even a primary center. In Orange Park, you have the medical center there is a primary, and then the other HCA hospital is Memorial. They're both primary stroke centers. Mayo, of course, is a primary stroke center, as is UF Health Jacksonville and UF Health Gainesville. The comprehensive centers that are currently operating in this region, Baptist is, as of 2015, an ACA Comprehensive Stroke Center. Mayo was a ACA Comprehensive Stroke Center from 2007 until 15, in which time they became the first Joint Commission Comprehensive Center in the state. UF Health Gainesville and Jacksonville were both ACA Comprehensive Centers. In 2015, Gainesville became the third Joint Commission Comprehensive Center in the state. Currently, Jacksonville is working on the process to become a comprehensive center. We've done our needs analysis. We're developing the policies and procedures and pathways necessary. And we're hoping to be able to apply for comprehensive sometime in the summer. After your application, there's a 4 to 6 month delay before your site visit. So with a little bit of luck, in the late fall, early winter of 2016, we'll also become a Joint Commission Comprehensive Center. We are JC Primary Center. Little history on the program. Dr. Scott Silliman came to UF Health Jacksonville, which at the time I believe was still UMC and just getting ready to become Shands, as the medical director of the stroke program. And we have been operating as a stroke program from the time he got there. It's been a growth and a learning process, but we started treating strokes back then. TPA use for strokes was in 1996. So it's right when the drug was approved for this therapy outside of research studies that we started. 2003, Dr. Silliman published in the Stroke Journal, which is the American Stroke Association's journal for stroke, an article that you may find interesting, and the slideshow has the link to it if you want to pull it. It's use of a field to stroke center helicopter transport program to extend thrombolytic therapy to rural residents. The reason you may find it very interesting is, one, this is the first and to date only research that is looking at using a helicopter transport service very similar to what trauma does to expand the footprint of the stroke center. And the data and the patients that were brought into the study were flown by mainly Trauma One. A Miss Vicki Huggett was one of the co-authors. Her name is now Vicki Coppin. You may be familiar with the name. She is our new stroke coordinator and was previously a flight nurse with Trauma 1. 2005, Joint Commission started certifying primary stroke centers in the U.S. UF Health was one of the first 50 to be certified in the U.S., and Mayo was also one of those first 50, and they actually received their certification within about a week of each other. 2004, the state of Florida wrote the first Stroke Act in the nation. They modeled it very closely to the Trauma Act that had been passed years before. One big difference is the Trauma Act says that trauma patients will be taken to a trauma center. The Stroke Act says they should. At the time of writing it, there were very few stroke centers in the state of Florida, and you could, if you were anywhere in the panhandle of Florida outside of Jacksonville and over at Pensacola, not have care, and that would have required EMS in those counties to transport times well beyond the treatment window at the time. So it was a little bit less stringent on where the patient should go. 2007, UF Health was approved as a comprehensive stroke center through ACA, just as Mayo was, again within a very short period of time, and later Gainesville was approved, I think, in 2009. Currently, our program is working on those things necessary to become a Joint Commission center. A little bit of the statistics on the program. Currently, we're getting patients from about 10 Florida counties and about 12 counties in Georgia. At one time, we were getting them from 17 counties in Florida and 12 to 15 counties up in Georgia. As other centers came online, patients were appropriately directed to closer facilities, and that decreased our footprint somewhat. We treat about 650 stroke patients per year, give or take a good 50 on that. That's been steady for almost 10 years, even though during that time frame we went from 2 stroke centers to 9 stroke centers in the region. So the volume of stroke patients continues to climb as the age of the population in the region continues to go up. Most stroke centers in the U.S. treat somewhere between 5 to 8% of their eligible patients with a therapy. Means that 92 to 95% of the patients only receive supportive therapy and rehabilitation. Our rate's closer to 12 to 14. It varies a little bit. Going along with that, there are some centers that have higher rates, but they also have a higher rate of treating conditions that proved later to not be a stroke in the first place. You diagnose a stroke about 24 hours after the occurrence by an MRI. If that's possible, you can use a few other imaging technologies. And we're low on the treating the stroke mimics as compared to some of those centers. We have a neurology residency program here. It's 3 years of residency. We train 4 per year, so at any given time there's 12 neurology residents. And that gives us the ability to have the resident meet the patient when they hit the ED. And from day one, they receive training on stroke care and the policies and procedures for it. So they're focused and ready for the stroke call, and we do simulation as part of their training. We currently have 8 attendings that take stroke call on a rotating basis. That's a very large number. I'm sure that the attendings would like for it to be an even larger number, but that's a fairly large number for neurologists taking call and are trained and qualified in giving TPA. We also have a vascular neurology fellowship program. That's the subspecialty for stroke. We have 2 fellows this year, 2 fellows next year, and that just the number will never be higher than 2, but whether or not we have 1 or none attending is based off of need and demand. So we'll have 2 for some time going forward in the future. Now our leadership is still based off of Dr. Silliman, who came here, as I said, in '96. He is a full professor of neurology. He's the medical director of the Comprehensive Stroke Program, medical director of the MS program, another subspecialty he has, and he's also the professor for the residency program. Our new stroke coordinator came to us in the second half of 15. Vicki Coppin, again, previously as a flight nurse with Trauma one of the original crew members with that program. She is on board overseeing the program on the inside. We have a ARNP, Loretta Schneppel. She works mainly with the patients on the neurology floor for North. She works with the residents and with nurses to support some of their educational efforts. Dr. Nader Antonios is a vascular neurologist within the program and actually did his fellowship here under Dr. Silliman. And then again, I'm Wayne Hodges, the outreach stroke coordinator or educator. Our treatment capabilities. What we have here at UF Health is we have the standard 3-hour primary IV TPA treatment window. That's the best treatment option for the patients, quickest, easiest. You're getting drug to the patient, hopefully reperfusion of the tissue the earliest. TPA works best if given in the first 90 minutes. There's a 3-hour window, and the national standard is that it takes 1 hour from door till needle time, and that's to do your CT, your lab work, chest x-ray, EKG, and do your assessment. We also have a 3 to 4.5 hour window. That is use of TPA off-label, and it's not a standard that primary centers have to meet. Many do, but it's using the drug off-label, and that causes some programs, especially those that are run mainly by emergency medicine physicians, to be a little bit more cautious. So it's an option for them. It's not mandatory. If it becomes approved for that expanded window, then it will probably be built into the primary. The next window goes out to about 8 hours, and that's interventional care. You can either inject TPA directly into the clot, which is in our arterial TPA, or you can do a clot retrieval. There are many devices out there. The first one that was out was the Mercy, which was like a corkscrew device that you would pull the clot out with. There's a suction device, the Penumbra device, and then the newest ones are stent devices such as the Solitaire. In this case, you push a guide wire through the clot, you open up a stent which pushes the clot against the walls of the vessel. It embeds it in the stent. It restores blood flow at that point, and then you can slowly pull it out. We also have neurosurgical support. We have a team of neurosurgeons here on campus that have been part of the trauma program since its inception. You also have to have endovascular neurosurgeons, and these are surgeons that are specialized in taking care of the vessels of the brain. About 15% of the strokes are hemorrhagic, maybe as little as 12%, and the rest of them are ischemic. The ischemic is the basic IV TPA and the clot retrieval. On the hemorrhagic, you may need to take off a section of the skull to allow swelling and evacuation of the blood, and then you have the aneurysms that you have to take care of. There's clippings of the aneurysm. That's done by removing part of the skull, and then there's coilings, which are done through a femoral approach. You put a very fine wire into the aneurysm. It makes a little bit of knot of wire, which in turn allows blood to clot, which basically builds a natural patch on the inside of the weakened vessel. As I said, only about 2% of the strokes qualify the subarachnoid hemorrhages and the aneurysm bleeds for that advanced procedure, but you have to have that as part of your capabilities as comprehensive. You also have to have research. Now we have ongoing pharmaceutical research, we have therapy research, we've done nursing research, and we're working on being able to start EMS research. You have to build an infrastructure. There's special HIPAA and human patient training has to be accomplished. I've been trying for many years to get EMS research going, and hopefully with our new coordinator on board, we can do that. The other capability that we do that's rather unique is working off of a teleconferencing platform. We're now doing EMS case conferences. What we do is we go back to a county and say, you had these cases that came to us, we think they're interesting, or the medic can submit cases that he sent in as he or she sent in as a stroke alert that they want more information on. And we set up a two-way video case conference where they stay in their county and even in their station, and they can connect virtually with a physician here. We have the emergency department go over the case, the neurologist, and even the neurosurgeon, neuroradiologist will review it. We're able to use the platform to bring up the patient images so that the medics can see that, and they can ask the team directly questions and get input on, did we miss something, did we not miss something, is there something we should have done better, those types of things. That's really unique, just anywhere in the U.S. Now I want to review those treatment windows for you because it's a little confusing if you're not in this every day. All primary centers have a 3-hour treatment window. All comprehensives have a 3-hour treatment window for IV TPA. There's an optional 3 to 4.5 hour window for IV TPA. Some primary centers may have it. Some of the stroke-ready hospitals I spoke about may or may not follow that. The comprehensives will definitely have that. If you're transporting to a center that you're not familiar with, you might want to touch base with them. Remember, the hospital needs the patient for 1 hour before the window expires. All right, the next window is the interventional window. Now, intervention, the clot retrievals, the IA, TPA, those basically go out to 8 hours. There are some centers that say 12 hours, but those are cases where the risk outweighs, or the benefit outweighs the risk, or you're in a situation where if you don't do this, the outcome is going to be very poor. And if you do it, the outcome may still be very poor. And the family is making a decision that they want a little bit more heroic therapy. But for the most part, it's 8 hours. The options would be, there are certain brainstem strokes where they may go after the clot out to 8 hours, or even in some cases out to 24 hours, because the alternative is virtually the same as the risk. You're either going to not have a good outcome or not make it, or you're not going to have a good outcome and not make it, but you have a shot at having a good outcome. Some of our research projects have had extended hours where some of those are looking at new drugs that are testing for a neuroprotective drug for stroke. We did one with albumin recently. There was magnesium sulfate was used out in California. So they're always looking for the neuroprotective drugs. There's some other therapies. Those research windows may go out as far as 24, even 48 hours. So for patients that have already missed their other treatment options, there may still be an option that they can receive at a comprehensive center doing research. Each center's doing different research. Mayo's doing different projects than what we're doing, and that's different than what Gainesville's doing. And the Baptist system trying to go to comprehensive is starting their research projects. So it might be a good idea to keep those in mind also. Now here's the basic contact information for us. Dr. Silliman is available for protocol questions or medical issues, or if you want, you can send those issues to me and I will discuss it with him and then get back with you. Vicki is handling patient questions, performance questions, flow questions, and patient support. We all have the standard first name dot last name dot jax.ufl.edu email address, and then the slide has Vicki's office number on it. My point is EMS education, EMS case conferences, and then other issues affecting stroke and EMS or stroke centers on a state and regional basis. And any other questions that you have about the program, you're welcome to contact me or Vicki if you want to go directly to her. We hope to be able to keep you updated on this, but I want you to understand UF Health Jacksonville is a comprehensive stroke program, and in 2016 we hope to be a Joint Commission certified comprehensive stroke program.